Well, hi guys. This is lecture to go along with the PowerPoint on gallbladder and biliary system. So we are in the positioning book and this begins on page 446. All right, in this first image, which is on 446, they are showing you how the liver sits and occupies most of the right upper quadrant. And looking at a patient from the front, you notice that you can barely make out the gallbladder, which is nestled underneath. So they're showing you how the right diaphragm is there, and we've talked in the past how the liver being so large actually pushes up on the right hemidiaphragm, so that side tends to sit a little bit higher. The right lung sits a little bit higher, and they talk about how that liver is actually the largest solid organ in the human body and weighs approximately 3 to 4 pounds, or 1/36 of the total body weight in an average adult. And like I said, it makes up most of the right upper quadrant. When we look at the biliary system, realize that this involves looking at the manufacture, the transport, and the storage of bile. Bile is actually made in the liver, transported by various ducts, and stored in the gallbladder if a patient has their gallbladder. Typically, that gallbladder sits in the posterior inferior region of the liver. In this next image, you can see that when you look at the liver from the anterior view or from the front, like we said, you can barely make out that gallbladder. But when you look from the back side or underneath, you can actually see it a little bit better. And this shows that the liver has 4 lobes. You have the right lobe and the left lobe, which are actually the 2 biggest lobes. And then if you look at the back side, you actually have what's called the caudate lobe and the quadrate lobe. Okay, so right lobe, left lobe, mainly that's all you can see from the front. And then the back side, you have the caudate lobe and the quadrate lobe. So there's 4 lobes total in the liver. And they're separated. You can see this falciform ligament separates the left from the caudate and the quadrate and the right. And then you've got the little pear-shaped gallbladder sitting here as well. All right, when we talk about the liver, it actually, the book tells you that the liver has more than 100 different functions, but I would tell you it's actually over 200 different functions. But the main function that most people recognize is that the liver produces bile. They tell you that the liver secretes 800 to 1,000 milliliters of bile, which is about 1 quart a day. But recognize that that's dependent on the patient's diet. If you're eating a lot of fatty foods, then that number, or how much bile you make, would actually be a lot higher, because bile actually aids in the digestion of fat by emulsifying or breaking down the fat globules, and it aids in the absorption of fat after digestion. Bile also has cholesterol, which is made soluble in the bile by the bile salts. So sometimes when they reference that, patients have hyperlipidemia or high cholesterol, it's not always diet related. It can be hereditary, in the fact that your liver actually, when it makes the bile and there's cholesterol in that, that's where it comes from, where it could be hereditary and not always related to your diet. Now, I said that bile is made in the liver, but it's stored in the gallbladder if a patient has a gallbladder. So if they have a gallbladder, this is actually the route that the bile would take. So bile is made in the liver, and from the liver, you've got the right hepatic duct and the left hepatic duct. So imagine the liver's up here, and that's where it's made. And then from the right side, it drains, and from the left side, it drains. And then it comes down, the 2 join to form the common hepatic duct. And from that point, if the bile is needed right away, it will continue down through the common bile duct and dump into the descending duodenum. If bile is not needed when it's made, it'll come down the common hepatic duct. It'll actually go through the cystic duct and be stored in the gallbladder to be used later. They do mention the pancreatic duct, and this is also aids in digestion. This comes from the pancreas, and that's where enzymes are released, and both enzymes and bile get dumped into the descending portion of the duodenum to aid in digestion. I would strongly suggest you guys look at this picture. We are going to talk about a couple different exams that they do where we are involved, and we actually look in a retrograde fashion up the common bile duct and the pancreatic duct. There's some older terms for that we'll look at in just a minute, but this is a very good picture to know the anatomy of. When we look at the gallbladder, it is pear-shaped, and there's three parts to it. You've got the fundus of the gallbladder, which is at the bottom, which is interesting because usually when we think of fundus, we think of the stomach where it's at the top. But this portion is the fundus, and then you've got the body of the gallbladder in the middle, and then you've got the neck of the gallbladder. Okay, and then you also have in the neck, you have this spiral valve, which is very tortuous or twisted, and then it leads into the cystic duct, then comes down into the common bile duct. Okay, so pear-shaped gallbladder, fundus, body, neck, spiral valve, which is very twisted and tortuous, to the cystic duct, and then down the common bile duct. Functions of the gallbladder, there's actually three functions. It's where bile is stored, it concentrates the bile, and it contracts when it gets stimulated. So if it's not needed for digestion, then the bile will actually go to the gallbladder and be stored for future use. Bile gets concentrated in the gallbladder because there's hydrolysis that takes place, or removal of water. And in a situation where too much water gets removed, what actually can happen is that you would form gallstones or choleliths. And a lot of patients have gallstones. Typically, it's not an issue. Let me go back. If the gallstones are in the fundus or the body and they're relatively large, then they're probably not going to go anywhere because they're not going to make it through the spiral valve. If they're small enough, however, to actually go into the spiral valve, sometimes what happens is they get blocked or lodged in that spiral valve, and that's when patients end up in excruciating pain, doubled over, nauseous, vomiting, just extremely painful to have gallstones. I've never had them. I still have my gallbladder, but I've seen enough patients to know that it's not something you would want. Gallstones, kidney stones, no kind of stone is fun, and it's not supposed to be in the body. And the third thing that the gallbladder does is that it contracts when fatty foods or fatty acids are present in the duodenum. So when you eat fatty foods, what happens is they stimulate the mucosa to secrete the hormone called cholecystokinin. And usually when they abbreviate that, they call it CCK. So CCK is cholecystokinin, and you end up with increases of CCK in your bloodstream caused by those fatty foods, and that makes the gallbladder contract, and the terminal opening of the common bile duct will relax, and that's how the bile goes from the gallbladder down into the descending duodenum to work on those fatty foods that we eat. All right, now, before we move on from this picture, I want to point something out. If you're still with me on page 447, they talk about that there's these two ducts. You've got the common bile duct, and if you notice on page 447, the common bile duct, they talk about that, and then the pancreatic duct. And in parentheses, they've got the duct of Wirsung. Okay, that duct of Worsung, that's an older term, but I will tell you that a lot of times that does show up on the registry. So the duct of Worsung is another term, an older term for the pancreatic duct. Also on 447 and not in this picture, they talk about the hepatopancreatic ampulla or the ampulla of Vater, and that's this area right in here. So the hepatopancreatic ampulla, and the older term is the ampulla of Vater. And then there's a sphincter down here that relaxes, and that is the hepatopancreatic sphincter. And the older term for that is the sphincter of Oddi. Now, both of these terms you'll find in figure 12.7 on 447, even though they're not actually on this particular slide. And the only reason I mention that is those older terms, the ampulla of Vater and the sphincter of Oddi, they like to throw those on the registry just to make sure that they're still being taught. Now, this is important because when we talk about a couple other exams like the ERCP and the postoperative cholangiogram, we're going to look back at this picture because that's actually where the insertion site of the scope is for an ERCP. Let me point out one more thing. I'm so sorry. Do you notice in this picture how the common bile duct joins with the pancreatic duct and it's coming in here as one separate duct? What happens in your book, it tells you that in about 60% of individuals, this is what happens. It forms one single opening into the descending duodenum. But in about 40% of adults, these are separate. So you would have one coming in as the common bile duct, and then this one would remain separate and come in as the pancreatic duct. So you'd actually have two openings into the duodenum, which with that, that's not so bad when they're two separate ducts. But what can happen, just like up here in the cystic duct, if you pass a stone and it actually makes it down here, what can happen is as these two join together, it gets very narrow. And sometimes the stones can lodge right in that single channel opening. And if that happens, if this gets blocked, then it would block up the common bile duct, which would cause pain for the patient because nothing could flow through. But it also could block the pancreatic duct and cause the patient to end up with pancreatitis, which is inflammation of the pancreas, again, extremely painful. So it says in about 40% of individuals, the ducts pass as two separate ducts. In 60% of individuals, the common bile duct and the pancreatic duct join to form one common passageway. But in those individuals, that single channel gets narrower and is a common site for impacted gallstones. All right, we look at this anatomic relationship of where the gallbladder sits in relation to the liver. Now notice this is the front of the patient. This is the back side of the patient. And they show you that the gallbladder sits very anterior and that the ductwork actually sits posterior. Okay, now that's interesting. It had to do with when you were positioning. If you were strictly looking at the gallbladder itself, then you tended to do images where the patient's anterior was closest to the IR. But if you were looking at the ductwork or trying to see if the ducts drain, then you would place the patient so that their posterior aspect was closer to the IR so it was easier to see. Notice we've got the liver all up here. You've got the cystic duct here. This would be right and left hepatic ducts, common hepatic duct, common bile duct, and then it dumps into the duodenum right here. This is the descending portion of the duodenum. Now, when we look on, if we look on page 448, this is figure 12.9, and they're actually showing you, they discuss in there how we used to take images of the gallbladder. It was called an oral cholecystogram. Okay, that's a thing of the past. You guys won't do those anymore. But what we used to do is a cholecystogram, an oral cholecystogram, or an OCG was done. And what we used to do is actually you would have the patient, prior to coming into the radiology department, they would go on a high-fat diet. The doctor would have them eat all kinds of fatty foods so that the gallbladder would end up emptying the bile that was stored. And then the patient was given what were called oral cholecystopathies. They're pretty much like barium pills, and they would be told to take those the night before. And what would happen is when the patient came in, those cholecystopathies would be absorbed by the gallbladder so that you could actually visualize the gallbladder on a radiograph. Okay, so we would bring them in, and then we would take an image of the gallbladder full of those oral cholecystopathies. They talk about, though, now, and we would do an LAO image of that. You can see that the patient is turned because the vertebral bodies are not nice and square. So that patient is actually in an LAO. All right, and then when they're in that LAO, you can see the different anatomy of the gallbladder. So this A right up here is the cystic duct, and then you've got the neck of the gallbladder right here and is pointing to with B. C is the body of the gallbladder, and then you've got the fundus of the gallbladder down here. Now this particular image, there are no stones, but sometimes when they had those oral cholecystopathies, you could actually make out the stones in the gallbladder. So once that image was done, then what we would do as students, we were told to take the patient down to the cafeteria, and we would do these in the morning. So we were told to get them a very fatty breakfast. So eggs with cheese, biscuits, butter, bacon, sausage, like greasy, fatty foods. And we would have to accompany them down there, and then we would eat breakfast with the patient. And then we'd bring them back up to the department, and we would put them under fluoro, because what you would actually see is the gallbladder contract to get rid of bile to work on the food that they just ate. But as they were getting rid of it, it was actually the contrast with the oral cholecystopathies in there. So the radiologist could take images of those. Now, imagine if you had gallstones, that would be very painful for the patient. So honestly, they don't really do those anymore. They tell you in the book that now that's been replaced by sonography. So we don't really do gallbladder imaging very much at all anymore, but ultrasound is actually taken over, or sonography replaced radiology, and they give you 4 different reasons for why that's the case. They tell you that first, there's no ionizing radiation for the patient, which is great, saves patient dose. It can detect much smaller stones on ultrasound than we could with a radiograph, because you can see here when they're showing you the gallbladder in this sonogram, if there was little tiny stones in there, they'd be a lot easier to visualize than we could with the radiograph. There's no contrast media used. With sonography, they use sound waves, so we don't have to use any of the oral cholecystopathies or any contrast media whatsoever. And also with the sonogram, there's a lot less patient prep. With an oral cholecystogram, like I said, they had to eat a high-fat diet, empty the gallbladder, and then they have to take those oral cholecystopathies. With sonography, all they have to do is be NPO 8 hours prior to the exam. So sonography is a lot quicker as far as diagnosis, no radiation, can see a lot smaller stones, and no contrast media is required, which is good for the patient. All right, now we're going to end up talking about the ERCP and a postoperative cholangiogram. So in your book, you're going to want to flip to page 716 and 717, because that's where these are spoken about. And this is that image we looked at just a few minutes ago when I was telling you that we take a scope and we actually look into these ducts, if there's 2 of them, if the common bile duct is separate and the pancreatic duct is separate, you would look in both. Or if they have a single channel, we would look in there as well. So on page 716, they talk about, oh, I'm sorry, my bad. On page 717, we're going to look at that first. On 717, they talk about an endoscopic retrograde cholangiographic pancreatography. That's full. Endoscopic retrograde cholangiographic pancreatography, or for short, we tend to call that an ERCP. Okay, ERCP, endoscopic retrograde cholangiographic pancreatography. So endoscopic means that we use an endoscope, which endo is within. So it's a scope that goes within the patient, and retrograde meaning backwards or against the normal flow. So we use an endoscope to visualize the biliary system and the main pancreatic duct. And a lot of times we're looking for residual stones or residual calculi or any strictures in that common passageway or in the two separate passageways. So the scope gets placed in the common bile duct or the main pancreatic duct under fluoroscopic guidance. So I'll go back. So the scope comes down. The patient is, typically they're not asleep, but they're kind of put in like a twilight state where you could wake them up and have them roll over or do something if you needed to. Otherwise, they're just kind of super sleepy and not really aware of what's going on. And the scope is placed in the patient's mouth, and it goes down their esophagus, through the stomach, then it ends up coming into the duodenum. And when I say retrograde, it's because normally things are coming from common bile duct and pancreatic duct into the duodenum and then continuing on. We bring the scope down, and then we actually insert the scope this way. And when I say we, I'm sorry, I mean the radiologist or the GI doc. Look up in the common bile duct or look into the pancreatic duct, and they're trying to see if there's any narrowing or strictures in this area or any stones that happen to be caught in that area. Sometimes if there are stones, they can use alligator forceps and kind of grab them and pull them out, and they usually let them continue on through the digestive system and pass out through the fecal material. If there's a stricture, sometimes they can put like a balloon in there and blow it up to stretch out that area. But this exam now is pretty much done in the GI doc offices, and this is your endoscopic retrograde cholangiographic pancreatography, or an ERCP. Okay, and again, that's on page 717 when you look at that. And then on page 716, we have the postoperative cholangiogram. Okay, postoperative meaning after surgery. So first, what the patient typically has done is an operative cholangiogram, meaning in the OR with the C-arm, probably the patient has had their gallbladder removed. Okay, so they had a cholecystectomy. So they went in the OR, they had their gallbladder removed, and they start with an operative cholangiogram, meaning that when the patient's done having the gallbladder removed, if the surgeon is concerned about residual stones or strictures, then what they'll do is they'll use fluoro and they'll inject contrast media into the ducts. They show you here that A is the right hepatic duct, B is the left hepatic duct, and then you come down into the common hepatic duct. Over here, you've got the common bile duct and the descending duodenum. So when they're in there, they put what's called a T-tube into the patient after the surgery when they flush through the contrast. If they're concerned about any stones that are left after the surgery, then they may order a post-operative cholangiogram or a T-tube cholangiogram. So the patient would come down to the radiology department after the surgery, and they would have what's called a T-tube catheter in place. okay? Meaning when they come down there, out of their abdomen, there will be like a little rubber catheter coming out, and it's one portion's coming out, and the T-tube is actually like this portion would be coming out towards us. Same with this. And the T-tube, the tube is in here. So imagine a catheter with one part of it going this way, and then off of it in the shape of a T is this coming to the outside. All right. The part that comes to the outside, we hook a syringe to that, and then the GI doc or the radiologist pushes contrast through, and then it can go up to the hepatic ducts and down the hepatic duct. It can go back up to the left and the right, and it can flush down towards the duodenum. And sometimes what they'll do is flush to see if they get rid of any stones that might be left there after surgery. Okay, so when they come down, that T-tube catheter is clamped off. When we first open it, we drain any excess bile that might be in there, and then push the contrast media. It gets injected into the patient through the T-tube catheter, and the radiologist is likely to take fluoroscopic spot images at that time. All right, and they're basically checking for any residual stones or any strictures in this area. I mean, look at all of the venous system that goes back to the liver. It's kind of crazy how much there is. So they're flushing both ways with that, and then you see it ends up going down the duodenum, and then it would continue out through the GI tract, and the patient would be none the wiser of that. Once they get done with that, a lot of times the radiologist will pull that T-tube catheter out. It's a very flexible catheter. When I say catheter, it's kind of the same material as oxygen tubing. That, you know, flexible, has not a lot of rigidity to it. And once they get what they need, the radiologist can just pull that out, and they put like steri strips or butterfly strips over the opening, because it's a very small opening, and then that heals fairly quickly. Okay, and that is a post-operative or a T-tube cholangiogram. All right, well, that takes care of the gallbladder and biliary system. Again, that's in chapter 19. These two exams are on page 716 and 717. And then this all came from chapter 12, which is gallbladder and biliary system and the upper gastrointestinal system.